Hi everyone and welcome back to the COVID-19 physiotherapy update. I'm delighted to introduce this next session, which is looking at discharge, advice and planning for COVID-19 patients and also the longer term effects of COVID. So our first speaker is already with me, Liam Campbell. I'm going to let him introduce himself and start sharing his slides. Please don't forget to put comments in the chat or DM me either via email, YouTube or Twitter. Thank you very much. Over to you, Liam.
Good morning. Thank you, Rachel, and thank you for inviting me to speak as well. So I will just start sharing my screen. So as Rachel said, my name's Liam. I am actually the specialist physiotherapist in long-term ventilation based in Lancashire teaching hospitals in the northwest of England. But we're very much involved with the inpatient management and discharge of our COVID-19 patients, as well along with a full team of a variety of healthcare professionals. So you can see there, I've just included one of my colleagues who's worked incredibly hard throughout the COVID pandemic and has pulled most of the information that I'm going to present today together so that we can have this discussion. So the aim of this presentation is really just to kind of talk about our experience of COVID-19 and discharging these patients back into the community once we feel safe, happy that they're at a safe point in their recovery pattern. So we very much carry out a discharge assessment when they've sufficiently recovered from their COVID-19 illness in hospital. They're declared medically fit for discharge by the team. Now, we want to ensure that any practitioners who are reviewing these patients on the kind of longer term basis and once they go into the community are aware of their COVID-19 status, because there are ongoing healthcare associated problems, which is being talked about in the next session. So it is worth us understanding those. So very much that diagnosis is documented on their hospital discharge letter and on their electronic letter as well. The patient's provided with a leaflet with ongoing contact details back to the trust and back to the follow-up team who are providing this support. So you can see on the screen there is just a very simple example of a UK discharge letter and some advice that we give to all of our patients. And as I said, that's really just to ensure that the patients are well aware of their COVID-19 status and that they can inform any other practitioners who are involved in their care at the same time. So all of our patients are assessed, and in the UK we normally follow this a very nice pathway of patients come in, they start their treatment, we assess them, and then we work on them to get them functionally ready to go home. And that covers a broad spectrum. Unfortunately, things have had to change very much with COVID-19, especially due to the bed capacity that we have in our local hospital as well. So today we have 150 COVID positive patients in our beds. So you can imagine that is taking up quite a significant capacity. For that reason, we're actually starting discharge assessment as soon as the patient is admitted to hospital, so that we have a very good understanding of what this patient's both physiotherapy but long-term social needs are, so that we can very quickly get them on that discharge pathway to ensure that they don't become stuck in the acute environment for long periods of time. As part of this holistic assessment, physiotherapists are involved to assess all of the functional needs of the patients, such as, and I've highlighted there, their mobility. So are they functionally mobile? Are they able to get themselves in and out of bed? Are they able to walk independently, or do they need walking aids, their muscle strength. So one of the things that we are seeing is patients requiring a lot of ventilatory support to get through their COVID-19 infection, as I'm sure my other speakers have discussed, and that can often leave a lot of these patients weak. So it's about having that initial assessment of their mobility before they move on. Physiotherapists will also assess the respiratory needs of the patients as well. So that doesn't necessarily translate into all healthcare environments, but here in the UK, physiotherapists also have a respiratory aspect as well. In some of the other nations around the world, they're called respiratory therapists, but we have a dual role in that purpose in the United Kingdom. What we'll look for is things like sputum retention. So we know that with COVID-19, there can in some patients be a huge sputum burden. So we want to ensure that patients are managing to clear their pulmonary system appropriately, as well as, and this is a huge thing, shortness of breath management. We are seeing a lot of patients with ongoing need for functional measures to reduce their shortness of breath. But these are covered a little bit later in this session. Other aspects that we think about include whether or not they can manage the stairs, what the home environment is like, and are there any social care needs. Now, we certainly can't do this as an individual group, so it's very much an MDT approach. And as I said before, this is as soon as the patient is admitted to hospital now. So the diagram that I'm sharing at the moment is a discharge to assess model. And we all have very different healthcare systems, but I just did want to share that because this is what we're starting to do. So we're no longer necessarily focusing on ensuring that a patient is at their maximum capacity before they leave the hospital environment. As their clinical condition improves, what we're actually trying to assess is, can this person go home now and have their follow-up assessment and rehabilitation in the community. So this has meant that a lot of our therapy assessment is now taking place outside of the hospital, and that we're having to push more of our therapists into these community settings as well. But again, as I said, we currently have 150 acute COVID patients within our beds, so we don't have patient flow if we don't make this decision to push the patients out as soon as we feel like they're medically fit. This does have implications for physiotherapy interventions, and it might be something that you guys need to consider within your own healthcare settings as to how as a physiotherapy team are you going to continue to review these patients who are, as I said, presenting with long-term needs. So these are just some of the questions that we ask as a multidisciplinary team within the discharge to assess model to support our discharge planning. And as I said, this is always now at the earliest opportunity. It's important to realise the implications that patients are being discharged very early, and that actually they are going to, as I said, need to have these long-term needs as well. We try to put an estimated date of discharge so that we can future plan our beds, but also so that the patients are well involved in their rehabilitation as well. So the discharge criteria that we consider really looks at the existing capacity of the healthcare system, what diagnostic resources we have available, the current pandemic situation, whether or not they've had clinical resolution and there's time elapsed, the severity of the disease that they've had, their current immune system, and evidence of viral clearance from the upper respiratory tract. So what we're doing at the moment is all of our patients must have had no fever and reduced their symptoms for at least 72 hours before we consider discharge planning or completing their discharge, and 2 negative COVID-19 swabs as well. And this is because we also have a huge problem with asymptomatic community transition in the United Kingdom. So whilst we do want patients out, and the patients want to be out of hospital as quickly as they possibly can, we also want to be mindful that we are not spreading coronavirus within the community at the same time. So as I was just saying, we have to have at least 2 samples testing negative for COVID-19 at least 24 hours apart to ensure that there's been no, that it's not an abnormal swab and that there's no reoccurrence of virus within the swab areas. So we in this country look at nasal and throat cultures as well. It also is there to ensure that there's not a false negative value on the first one, because as many people are aware, the COVID-19 swabs are currently about 70% effective in picking up the trace of the virus. So again, that's to stop community transmission. For the symptomatic patients, after they've had resolution of their symptoms, we do try and collect samples at least 7 days, or as I said, 3 days without fever. Or if they are, we should try to aim to take 14 days after the initial positive test. We do struggle, if I'm honest, with that 14 days after the positive test, because often we've now put these patients, certainly from the first wave of the pandemic, have moved back into the community at that point. What we did want to highlight was that we do discharge some of the patients before fulfilling this criteria, but more so if they are in environments where they can self-isolate. So we have a very multicultural population within the northwest of England, and therefore one symptomatic patient going into a large household does have the ability to infect others. So we would consider that within our discharge planning at the same time, whereas somebody who lives by themselves can easily self-isolate for the minimum values of time that our government are currently predicting for patients. And as I said, so there's the isolation advice that we're currently giving. There is a varying degree of community transmission in the UK, and we're only seeing this increase at the moment. And as I'm sure many of you are aware, we've now gone into another 4-week government enforced lockdown within England to try and reduce the spread of our community transmission as well. We don't know the exact duration of infectivity, and that's still some ongoing work, but the figures that we give are based on the best evidence that is available and when symptoms have certainly decreased. We do advise that all patients should continue to self-isolate for the figures displayed on the screen. Now, what we mean by mild to moderate is no or very mild symptoms. So these are patients who have perhaps required just a very small amount of oxygen, less than 28%, and have normal prognostic factors. So what we look at on blood tests are a chemical called interleukin-6, and their inflammatory markers to be able to see how much of an infection, how much a response the body is having. If those remain very low, then we would classify that as a mild to moderate and suggest a continuous self-isolation for 10 days. The severe aspect certainly are any immunocompromised patients. and actually we're now pushing for going back to a shielding model with these patients, to ensure that they're protected more so. We include patients who have had an ICU admission, been on CPAP, been proned, and required more than 28% of oxygen, or they have significant respiratory comorbidities. So thinking of our severe asthma patients and our COPD patients there. Anybody who's had significantly increased prognostic markers, abnormal radiology changes, or have ongoing symptoms. We also include patients who have thrombosis risk as well, and we know that COVID-19 does increase that at the same time. So this is a very busy slide, and it's just to be given as an example. It's not for you to necessarily follow, but that's the pathways and that are being developed from within Europe, and you can access that pathway from the link on the slide as well. The other thing that we're thinking about when we're thinking of discharge is the infection prevention control aspect of trying to keep these patients well within the community as well, but also trying to discharge them safely. So the video there does go through some of the ongoing management techniques of trying to reduce the infection and prevention control aspect as well. Some patients are being given devices to go home with, and I think we do need to consider on discharge the infection prevention control aspect of medical devices as well, to ensure that there isn't a community spread with patients using devices that have been shared. And the current guidance that we have is that these should be cleaned on a regular basis, and that COVID-19 can live on some surfaces between 5 and 9 days. Therefore, trying to isolate some of these devices or use single patient devices to take home are well within the best ways forward. So just coming back to that original slide that I showed, is really to think about that top bullet point, the physiotherapy needs assessment, and remember what the physiotherapy assessment for discharge is, and therefore the advice that we would offer from a physio perspective. And it very much at the moment tends to focus on those two highlighted bullet points, which are mobility and our respiratory care. So managing some of these symptoms, it is important to acknowledge that everybody is presenting with a slightly different course post COVID-19 infection, and that there are individual stages of recovery. And I know the next speaker is going to talk a little bit more about that, so I won't stand on her toes. We are looking to provide exercise programs and treatment strategies as appropriate. One of the things in the UK that's being discussed at the moment is a lot of these patients are being pushed towards pulmonary rehabilitation programs to try to rebuild up muscle loss and fatigue and manage their breathlessness. The larger question there is whether or not pulmonary rehab itself is the most appropriate tool for this, or do we need to be thinking about more individualized exercise programs for these patients, or exercise programs that are developed slightly differently from pulmonary rehab? COVID-19 is slightly more multifactorial. As I said, we're thinking of things like thrombosis with these patients as well. As I said, there is going to be more about ongoing management of this in the later session today. But the biggest ones that we face upon discharge are shortness of breath and fatigue. So what we want to think about is the 6 Ps of managing both of those things. So prioritize. What we're asking the patients to do is really think about what they want to achieve by any task, and look at tasks that are the most critical for them. Plan how they're going to do that and ensure that they have help if needed. Positioning, so this is both from a functional point of view but also from a respiratory point of view. Can they use positioning? And this is something as physiotherapists we do quite a lot, to relieve any breathlessness. So we all have seen our COPD patients very much in a 3-point lean, and this is quite beneficial in the COVID-19 patients as well as in lying as well, so recovery positions. And you've already had talks about proning within the ICU and on the wards, but actually patients can self-prone in their home environment as well to reduce their fatigue levels and reduce that breathlessness. Pacing and ensuring that the patient is pacing themselves and not trying to kind of overcome any fatigue levels too quickly. And that's often a problem with patients, just trying to rein them back in a little bit. They often feel that they're much better, but they need that little bit of support. Remaining positive. So this is quite a frightening time for lots of the patients, as well as for healthcare staff as well. So it's about trying to remain positive on the patient's behalf, but trying to install a positive attitude with them to take part in any rehabilitation that we are able to offer. And then one of the huge ones that we're using before discharge to manage symptoms whilst in hospital, but certainly within the community as well, is pursed-lipped breathing, just to try and to reduce some of that fatigue level as well. So the patient experience that we're seeing from discharge are that some are very keen to go home and avoid risk of any further infections, and that's not necessarily COVID-19. That can be other hospital-acquired infections. They are, however, very anxious and worried on discharge about managing at home and managing in these environments where they're perhaps not going to be supported quite as much. One of the other things that we're seeing is cultural beliefs have an impact. So some people want to go home to the care of their families. Other people, as I said, are concerned about infecting their families, and their beliefs around healthcare only happening in hospitals are also having to be modified at present as well. We're also, as well as the advice from the 6 Ps, we're also trying to give advice on symptoms such as sleeping difficulties. And again, this can be related back to breathlessness or feeling worried and anxiousness, racing heart or fast breathing, and difficulty controlling their thoughts. And we do have access to some very helpful psychologists through the service. There are also some free apps for patients to try and get them to focus more on the here and now, especially with those difficult thoughts and reminiscing about their time within hospital. Talking with them, so we are doing a telephone clinic follow-up and some face-to-face with some of the ongoing unwell patients. So it is quite important that these patients are able to discuss their understanding of the illness that they've had as well. We are offering some safety netting at the same time to try and pick up any patients who are continuing to deteriorate. So the standard is to have a telephone call the day after discharge to check that they continue to remain well and offer any ongoing advice. What we are aware of is that there is some ongoing silent hypoxia within the first few days. So we're currently trying to institute a home pulse oximetry plan across our integrated care services to look at ensuring that these patients are managed in the most appropriate function. We are seeing most of these patients fully recover from a breathlessness and functional point within 10 days. But as I said, there are some ongoing longer cases as well. The ongoing safety netting advice with regards to includes severe breathlessness, providing advice to the patient on what to do if they have any problems, particularly if they're being discharged very early in that pathway as well. We're explaining the silent hypoxia. As I said, some services, and it's going to be a regional thing where we are providing home oxygen. We're ensuring that if any of the symptoms on the screen that are being shown at the moment are active with any of these patients, then that they're having the best medical review, or we're booking them back into follow-up clinic here at the hospital as well. So we have also created a COVID virtual follow-up team to ensure that those patients have access to clinicians as and when they need them. So as you can see from the titles there, we do have a variety of patients, practitioners in there, with 2 physiotherapists, being Kath Edwards, who's also one of our advanced COPD practitioners, and Jennifer Harrison, who is our lead physio for airways and bronchiectasis. What I will say is that Jenny's also a breathing pattern disorder physio, and this is we are picking up a few of the COVID-19 patients who are just fitting into that breathing pattern disorder as well. So that might be something that needs to be considered on discharge. And if this is safety netting available, is this breathlessness purely COVID-19 related, or is there some multifactorial aspects there as well? And if you can tap into those services, that is fantastic. Here in the Trust, we also created a COVID-19 recovery resource. And this was predominantly aimed at patients with clinicians in mind, to allow us to provide them with as much support at home, both from clinicians but via the web as well. It's web-based. It's available on all digital platforms. I'll give you the link in just a second. And it really has been developed by a multidisciplinary team. So we've got nutritional advice, ongoing physio advice, occupational therapy, breathlessness management, psychology management, and functional ability management as well. What I will say is that it is a fantastic resource. If it's not available in your country, and we have had a few issues with that, please get in touch with either Rachel, or I'm happy for my details to be passed on. Currently we're aware that it's been accessed by 70,000 people in about 70 countries. But as I said, we are finding that some places are not quite up to scratch, and we've not made it available to all of the countries in the world. So let us know. And that is me for this morning.
Thanks, Liam. That was brilliant. Thank you so much. So when you just stop sharing your screen there, we've got a question from Kim, who asked, does anyone get discharged with knowledge of how to monitor their heart rate or saturations with exertion during function to manage their fatigue, shortness of breath? So I've just put in the chat that it's very different in different centres in the UK, but some people are being sent home with pulse oximeters. But
very much so. So it is that it's not standard across the United Kingdom for patients to be sent home with pulse oximeters. There was a local trial in East Lancashire, which is one of our neighbouring trusts, which was found to be incredibly positive at helping manage these patients, as well as pick up some of the silent hypoxia that we're seeing as well. So across our England split into integrated care services as well as local hospital trusts. So actually it's been found to be so beneficial that our integrated care trusts are introducing this across Lancashire to help these patients manage. The plan is that this will be coordinated by volunteers, and the equipment picked up and passed on to the next patient as is appropriate, and just to help those patients manage their ongoing activity and fatigue levels.
Fabulous. Well, thank you so much for such a comprehensive talk and being bang on time. We'll definitely get your details out there to share with people as well. So thank you so much, Liam. That was brilliant.
Fantastic. Thank you very much and have a lovely day.
Thank you. So
Thanks.
This brings us on to our wonderful next speaker, Sam. Now I'll let Sam do a full introduction of herself and where she's from, but Sam's an occupational therapist, and here in the UK, we are really, fortunate to have a really strong occupational therapy presence throughout the critical care and discharge pathway. We definitely don't have enough OTs in critical care, in acute medicine, or in respiratory in general. But when we do have OTs, certainly the overwhelming expertise and diversity of thought that you guys bring is not only very much appreciated, but obviously enhances patient care. So I'm really grateful for Sam for doing this talk. She's going to cover everything that a physio needs to know and a bit more. So over to you, Sam, if you can start sharing your screen. Thanks.
Oh, thank you, Rachel. So my name's Sam. Let me just share my screen. Is it screen 1 that I'd have to share with Rachel? Do you know? I want to make sure I'm sharing the right.
Just give it a go. I didn't know there was more than one.
Hopefully you can all see this.
Yes, that looks perfect.
Perfect. So yeah, hello everyone. So my name is Sam and I'm an occupational therapist. My background is in stroke and neurology, but I've joined the critical care team down in Cornwall in England just in January. So we are quite a new service. We're still trying to establish, sort of find our feet and find our pathways and things, but we've done some really exciting things this year. So hopefully today can give you a little bit of information, a bit of guidance on the longer term effects of COVID-19. And some of the things that we'll be covering today is to understand the long-term effects and the impact on occupational performance following COVID-19, with a particular focus on post-viral fatigue, cognitive functions and breathlessness. These seem to be the most common symptoms and effects that people are having post-COVID-19, and hopefully to develop some functional strategies and assessment considerations for you to use with your patients to promote recovery. So the COVID-19 guidance on the long-term effects, which was published a couple of months ago, suggested that around 10% of mild coronavirus cases who are not admitted to hospital have reported symptoms lasting more than 4 weeks. And a number of hospitalised cases reported continuing symptoms for 8 weeks or more following discharge. So obviously it's quite a big impact, and we've all heard of the term long COVID, and the research is ongoing to evaluate the long-term health and psychosocial effects of COVID-19. There are 2 major major studies going along, which you can see there, the post-hospitalisation COVID-19 study in the UK and the ISA-RIC Global COVID-19 long-term follow-up case study, which would be good to have a closer look at. And we all know, but just a sort of a refresher of some of the persistent health problems that we find for people who've had the coronavirus. So obviously the respiratory symptoms, including chronic cough, shortness of breath, lung inflammation and fibrosis, and pulmonary vascular disease. People also experiencing cardiovascular symptoms, including chest tightness, acute myocarditis and heart failure. Mental health problems and cognitive difficulties, which obviously I've got quite an interest in being an OT, and also the impact on social isolation and going back out into the wider community and back to ADLs. People obviously experiencing loss of change of smell and taste, persistent headaches, gastro disturbances, fatigue, weakness, sleep disturbances, liver and kidney dysfunction and clotting disorders. And guidance from the British Thoracic Society has recommended that a post-COVID assessment should include assessment and management of breathlessness, symptom or palliative care management where required, assessment and management of oxygen requirements, Rehabilitation needs an onward assessment, and again, I'm quite pro this being an MDT rehabilitation sort of assessment. Assessment of psychosocial needs, management and of anxiety, assessment and management of dysfunctional breathing, and considerations of a new diagnosis of a VTE. So where I'm in England, we are down in the southwest, so we our cases that we've had have been a lot smaller than some of my colleagues in the rest of England. So I haven't got a huge comparison to compare it to, but from the patients that we've had, just thought I'd give you a little bit of an update. So we've been following our patients from critical care out into the community, and we're still following some of those people up now, and we've been working with them for a period of 6 months. And what we found is that people are still being implicated with fatigue, breathlessness, cognitive difficulties, including information processing, which can sometimes be misinterpreted for memory difficulties. People are still struggling with sleep or having nightmares or not getting good quality of sleep, and social avoidance. And obviously this has impacted on occupational performance in areas of work, hobbies, driving and social interactions. So it's really important that we provide like a holistic rehabilitation programme for these people to enable them to get back to being independent again. And we're going to focus on a couple of these symptoms and effects now. So we'll start with fatigue. The WHO classification of have defined post-viral fatigue as a complex medical condition categorised by long-term fatigue and other symptoms. These symptoms are to such a degree that it limits the person's ability to carry out ordinary daily activities. And some symptoms, obviously including headaches, reduced attention or difficulty concentrating and focusing on things, and unexplained pain in the body. And I think it's really important to remember that fatigue isn't just, people don't get fatigue just from carrying out physical activities. They can also get social fatigue, emotional fatigue, and even fatigue just from concentrating, things like reading a book. So it's really important that we try and monitor and try and find out the trigger points, so we can put in sort of a good treatment plan to work out how we can sort of manage fatigue on a day-to-day basis. And one of the ways of monitoring fatigue is looking at a fatigue chart. So when you're working with your patients, either in hospital or at home, looking at sort of the time of, so on the left-hand side, you can see the column there, keeping a record of the time of day, whether it's morning, afternoon or evening, how many days post they've had their diagnosis. And before you start your session with the patients, ask them to sort of give a rough percentage of how fatigued they're feeling before the session. And there's lots of great different ways that people look into this. For example, like how much fuel have you got left in your tank? But giving a percentage is quite a good sort of objective way of measuring. And then really clearly articulating the task, including the load and the environmental demand. And then after the session, looking at how fatigued they're feeling after the session as well. And by this, you're just sort of creating a pattern and getting a good understanding of the triggers of fatigue, which help you come up with some good treatment plans. And here are just some suggestions of how we can manage post-viral fatigue that are really practical, and we can work with our patients. So obviously resting, making sure that we've got good nutrition, being moving, so not avoiding moving just because you're feeling tired, even if you're doing it just a little bit every day helps. Slowly increasing activity, allowing yourself time and giving yourself permission to feel the way that you're feeling, making it fun, having a routine, and obviously a medical review to rule out anything else that might be going on as what's causing the fatigue, for example, low iron. Okay, cognition. I can talk about this all day, but I won't. So hopefully I'm just trying to think of a couple of strategies that might be useful for when you are working with your patients from a physical point of view. Sometimes cognition is quite is overseen, but if you talk to any OTs who've sort of had an interest in cognitive function, they'll probably get quite excited if they're like me, because it's something that can be treated. It's just like as if you were treating a physical muscle. You can treat cognition with cognitive rehab, but so cognition is the mental action or process of acquiring knowledge and understanding through thought, experience, and senses. And when we assess cognition, we look at this structure called the hierarchy of cognition. So we focus on all these different areas and try and really work out what it is the cognitive deficits are, so we can create good treatment plans. But today I'm just going to be touching on the attention side and the information processing side, as that's the two areas that I found with our patients who we're working with have covered the most areas of difficulty. So with attention, again, we look at this sort of structure and this hierarchy of things to assess. So in order to be able to have good attention, we need to make sure that we can focus on something. We need to make sure that we can sustain our attention for that long. So for example, you watching me on this talk, being able to make sure that you can sustain it long enough for you to take the information in. Being selective, so blocking out any background noise, and it might be whilst you're watching this video, you've got maybe the dog barking in the background, or the phone going off. Can you block out those sorts of that selective attention and just focus on the task in hand? And then alternating and divided attention, so the ability to complete 2 or more tasks at once. And from a physiotherapy point of view, when you're working with your patients, you might find that you're helping sit your patient on the edge of a bed, or you're completing an activity with them, but they might look a bit phased out. They might look as though they're not really focusing exactly on you. And it's really important to sort of address, because if they're not focusing on you, if they're not attending to you and what you're saying, that information is not going to go in, and they're not going to be able to retain it and then later on down the line recall it later. So you might find that obviously that really impacts on progressing with rehab. So it's really important that we address attention difficulties. Which then sort of jump in a couple of steps leading on to information processing. So information processing happens in 3 steps. So the first step being reception, so obviously through attention, so you need to get that information coming in, and then in the brain it's processing all the stimuli and all the senses that's going on, and we are finding that some patients have difficulty with processing information, the actual part in their brain. So information processing is building patterns in your brain to help you remember things, and using different strategies to help you learn. So for example, learning to drive a car, for those who drive, remember the very first few driving lessons that you would have had, and you've had to really concentrate, you'd be coming up with different strategies and things to help you remember. And then as you become more and more experienced and you practice these skills over a period of time, these skills become more automatic. So it might be that you'll be driving home and you can't remember how you got there, but you got there safely, obviously. It's exactly the same with our patients. So when you're working with them, helping to try and rebuild, or working on improving a really good quality sit to stand, you might find that you have to really keep practicing and keep re-educating. For a patient, it might be really difficult for them to try and remember how to relearn that quality stand, for example. Maury explains very well. Like I said, I can go into this all day, but it's a really important thing. So if you are interested in how cognition impacts you from a physiotherapy point of view, speak to your OTs if you have them. Okay, I'm whizzing through. Some of the treatment methods that you can work for information processing difficulties. So avoiding information overload, give the patient permission to say no. They can change the way that you ask the question, or look at different sensory inputs. So like I said earlier, with the way the information is going in through attention, you might use alternative ways rather than auditory, looking at maybe visual ways. If you're working with a group of other therapists, maybe have one person leading the session, keep questions brief, change the environment where you can, block out background noise, reassure and regulate, and introduce the sessions and then summarise at the end of the session. So breathlessness, so your assessment, obviously you'd be ruling out any organic cause that explains the symptoms. As you would all be doing your subjective assessments, asking open-ended questions, having a full history of symptoms, including triggers and alleviators. The variability of symptoms, including the trends, improving or worsening, looking at lifestyle, diet, exercise, occupation and sleep, and looking at any stress and associated anxiety. Obviously, we know that breathlessness and anxiety come hand in hand. And then looking at your objective assessment, and again, for physios, this will probably come a lot more naturally than it would to me, but looking at rate, flow, passage of air and pattern at rest and on exertion, looking at posture and an MSK assessment. So exercise testing, again, you probably have all heard of these ones, the 1 minute sit to stand test and a 6 minute walk test, doing your pre and post heart rate, oxygen stats and Borg scale, and oxygen stats measured throughout the test. And just being really mindful as well, if you're looking at measuring a patient's oxygen levels during your assessments, if they've got particular anxiety, just be careful of how you deliver that information. And we've worked with patients who, unless they're getting 100% or close to 100% oxygen levels whilst doing these tests, they become more and more anxious. So just be really mindful of how you deliver that, and just provide lots of reassurance. And obviously being an OT, so providing lots of, you can test for exercise through functional assessments and ADLs, and asking patients of their sort of satisfaction of how they are feeling. And you've also got the Brompton Pattern Assessment Scale, and there's a little QR code down there at the bottom for you to have a closer look at that if you're not already familiar. So treatment for breathlessness, I was taking an MDT approach, breathing pattern retraining at rest and on exertion, postural and breathing pattern education, first rib, chest wall, shoulder girdle and spinal mobility, relaxation, so things like mindfulness, lifestyle management, having a good diet and having a functional approach of routine. As we know, breathlessness and anxiety come hand in hand, and a good way to manage anxiety for some people is to keep things in a routine and taking a functional approach. Other considerations, having a sleep assessment with interventions, and I've just got a slide for a couple of ideas of how you can assess sleep. Thinking about people returning to work, what sort of work they do, is it a physical job, is it a more of an office-based job, looking at the demands in the environment, social interactions and responsibilities, a person's roles and identity, so roles within their family and roles within the community. Obviously having an identity is so important. It's who we are, it's you know, our values and our morals, so we need to make sure that we consider that for people. Returning to physical activity and high demand ADLs, so put that things like managing finances, for example. And implications on occupational performance, so obviously difficulties engaging with society, avoiding and relationship changes. So we've had a couple of cases where our patients have really struggled have avoided social situations and have found that relationships with loved ones have changed, maybe leaving more of a spouse role and becoming more of a caring role. So we, and that's not just for the patient, but for the loved ones too. Increased anxieties and fears. So having people, some people are worried about catching the coronavirus again, or whether the way that they're feeling now is going to be how they're feeling for you know, for the rest of their life, and is things going to get better. And obviously that comes with them with a significant amount of fear. Sleep disturbances, people becoming more socially isolated, difficulties with ADLs from fatigue, breathlessness and cognitive issues like we've briefly touched on, which obviously impact on finance, return to work and driving. And just like I'd say a brief sleep therapy assessment. So looking at the questions that you'd ask, how someone would normally sleep, what their sleep is like before they came into hospital, and then looking at the environmental, psychological and the physical reasons why people can't sleep, and then you can create your treatment plans based around that. So I won't go into too much detail of that because I'm just conscious of the time. But the conclusions, so obviously there are long-term health and psychosocial effects of COVID-19, which are multifactorial. Therapists have an important role to play in the assessment and treatment, and it's really important to take that MDT approach, so working with your dietitians, your speech therapists, your OTs, your psychologists, your nurses, your doctors, to optimise someone's level of care, because they all interlink. So yeah, and there is a high prevalence of fatigue post-COVID. Breathing pattern disorders are prevalent post-COVID, but it's important to rule out other organic causes, and a holistic approach should be taken into account, including social implications, anxiety and functional difficulties. And there are just a couple of resources there for you to take a look at, and I'll just give credit to a physiotherapy colleague, Charlotte, who helped put together the actual physical sides of this presentation. So hopefully you've got a couple of bits to take away with you. I will stop sharing my screen, hopefully.
Yeah, thank you so much. Just checking the chat box. So that was a great presentation. I mean, one of the hardest things to manage is the combined fatigue and cognitive, like brain fog that people are describing. I think added into that is the social isolation, so the government restrictions that we have, not just in the UK, but worldwide, globally, and the fear. So, I mean, where do you even start as a therapist when you're looking after these patients? Like, I think for some therapists it's really overwhelming to think, what do you start with, what advice do you give, because information overload as well isn't a good thing. So we know that the breathlessness and fatigue are two of the most debilitating factors, and the cognitive impairment, so the lack of concentration that you described. So what advice do you have for people?
That's a really good question. And obviously as therapists, we've changed the way that we're working as well. So a lot of our treatments at the moment have been virtually or on the phone. And we were initially, as therapists, managing lots of these difficulties over the phone and trying to provide that reassurance. What we found though was working sort of face to face with people just to sort of reassure them, and sort of being there in person, you sort of got that different level of feedback. So where you can, if you've got a patient who's really, really struggling and you can't manage to reassure and provide your treatment sessions over the phone or virtually, then to just get out there to see them. We've gone out a couple of times to see people who've been really struggling, and just by having that human sort of contact at a social distance level has provided reassurance and sort of got them back onto the right trail of road of recovery. Just developing really healthy positive coping strategies, so to provide maybe information, not maybe in leaflets, everyone benefits from receiving information in different ways. So if leaflets might not work, might be too overwhelming, maybe or like giving a call might not also be working. It really is patient specific, so try and tailor your treatment plans based on the person's needs and really just keep reevaluating and providing the guidelines.
Thank you so much. There's a couple of questions about the Brompton breathing pattern scale, but I can certainly just pop my email in the chat. But if you do Google it, it does come up. And I know on one of the slides, there is the breathing pattern assessment scale on there. So what we're going to do is make all the slides available as a PDF just on a Google form online. So you can just click on it and get all of the presentations as a PDF. So we'll include some of the appendices and that as well. I think the other question that's come through is around vocation. Mm-hmm. So a lot of the patients we've had in the UK have been younger patients who need to work, who are also parents. But the infrastructure for that, I would say, probably to be fair in the UK, is that we would want to provide so much more than what we do in terms of vocational rehab. So do you have any top tips for people with regards to that? For whether there might not be a lot of therapists available. Yeah.
So I think we're really beneficial with it being in the role that I'm in, is that we are able to support people back into work and provide those therapy sessions. But in the interim, for those who can't work, we would support with applications for benefits. So obviously, it has the financial implications as well. So I have a patient at the moment who is a nurse, and obviously the nursing role is very physical, it's very psychologically demanding as well. So we were just taking it month by month to see how he's feeling and what his difficulties are. We're not really looking at returning to work imminently with him. So he's 6 months post his critical care stay. And he wants to get back to working in healthcare, but it might be looking at what other roles he can do. So by just providing that holistic assessment, looking at the environmental demands of the job, and looking at the patient's needs, and just really breaking down to see whether they're able to physically and psychologically and mentally be able to go back to that sort of vocation. If not, are there alternative ways that we can go? We want to try and get people back to as near possible to what they were doing before they came into hospital. That's our aim, but obviously that's not going to be appropriate for everybody. So then it's looking at providing that support to learning to readapt and changing that lifestyle as well, and being there from that point of view.
So that's such good advice, and that's what we've said. A lot of it is like lifestyle adaptations as well as lifestyle behaviours. And we'll particularly see that because a large percentage of our patients have maybe had obesity or had a really inactive lifestyle. And it's really about that behaviour modification and the longer term management as well. So which adds into the fatigue and the cognitive issues and the sleep disorders that we're seeing. So yeah, for sure. Mm-hmm. Well, thanks so much for your excellent talk. Really appreciate it, Sam, and showcasing absolute added value and benefit of the amazing occupational therapists we work with. So thank you. Now,
thank you for having me.
For everyone, we're going to stop streaming now. We're going to have a 30-minute break, so we will be coming back online at 11 a.m. Greenwich Mean Time, and that makes it 1 p.m.